Hi, everyone. I'm Mikkael Sekeres, Chief of the Division of Haematology at the Sylvester Comprehensive Cancer Center at the University of Miami, and I'm going to be talking about novel strategies to treat higher-risk myelodysplastic syndromes. I think one of the first strategies is just to define what we mean by higher-risk MDS. This is often defined using the International Prognostic Scoring System, or IPSS, as patients who fall into intermediate 2 or high-risk groups. With the revised IPSS, it would be patients who have an IPSS-R score that's greater than 3.5. But actually, it's much more complicated than that. And what we're seeing more and more of is molecular mutations being incorporated into these clinical prognostic systems, which we use for essentially staging in myelodysplastic syndromes. My rough back of the envelope way of incorporating these is to think about certain mutations that are traditionally poor risk, such as P53, ASXL1, EZH2, as upstaging the patient one risk group using the IPSS or revised IPSS. So for example, a patient in the classic IPSS who would be classified as having intermediate 1 risk MDS, but also has a P53 abnormality, we would think of as having a prognosis more similar to intermediate 2 risk MDS patients. This patient then would also be considered to be higher risk. Classically, with higher risk MDS patients, we use hypomethylating agents to treat their MDS, and we discuss the notion of hematopoietic cell transplantation for these patients, which represents the only potential cure for somebody with MDS. There have been a number of research studies that have tried to build on this hypomethylating agent backbone and given combination therapies to patients with MDS. There was a large study conducted in the United States, actually called the North American Intergroup MDS Study, the United States and Canada, that randomized patients to receive azacitidine alone or in combination with lenalidomide or with the histone deacetylase inhibitor vorinostat. In this study, there was no significant improvement in overall response rate for patients who received combinations. But one thing we learned from this study is that a lot of docs and a lot of patients were discontinuing their therapy prematurely or reducing the doses of their therapies in a way that wasn't actually specified by the protocol, and that this probably compromised efficacy of the combinations. So as more and more studies are combining drugs for treating higher risk MDS, our strong caution is to have language that's very clear in those protocols and a back and forth with investigators about maintaining dosing strategies of both agents in treating patients with higher risk MDS. When this happens, we find that the efficacy rates are actually much more improved. One example of this is a recent study that's been published in Leukemia that randomized patients to receive azacitidine monotherapy or azacitidine combined with a NED8 inhibitor, pevonedistat. In this study, there was a significant improvement in event-free survival for patients who received a combination of azacitidine and pevonedistat versus azacitidine alone. There was also a numerically higher overall survival improvement for those who received a combination, although the study wasn't powered to show an overall survival advantage. This study has now moved into a phase 3 setting that will be powered to look at overall survival. One of the reasons this study is considered a success is because, once again, the back and forth with investigators and the language in the protocol encourage the investigators to keep patients on the combination for longer periods of time without reducing that dose. There are ongoing studies of a number of combinations, including combinations of hypomethylating agents with venetoclax, which have shown an overall survival advantage in older adults with acute myeloid leukemia compared to azacitidine monotherapy, but haven't yet been proven to be superior to hypomethylating agent monotherapy in higher risk MDS. So we do still consider this to be experimental, and we do think we need to work on the dose and schedule of the venetoclax to find the ideal combination in patients with higher risk MDS. One final approach that we're using to look at novel ways of treating patients with higher risk MDS is to capitalize on their molecular profile. There was a study that was just published in the Journal of Clinical Oncology looking at the combination of azacitidine with APR-246. This is a drug that restores TP53 function. There were very high response rates, over 70%, that were reported in that study, and those response rates seem to be durable. Now, preliminary results from a phase 3 trial have shown that while the combination did improve response rates from 20% in azacitidine to 30% in the combination of azacitidine and APR-246, that study didn't meet its primary endpoint. Again, these are preliminary data that we've seen. We're waiting for formal reports to come out that can be critically appraised. Other ways of approaching the molecular profile is to use drugs that target IDH1 or IDH2, that's ivosidenib or enasidenib, which have been shown even in patients who've been exposed to hypomethylating agents in the past to have response rates that are 40% and that last about 6 to 8 months, which is actually considered quite good, particularly in patients who've been exposed to hypomethylating agents in the past. So to summarize, what we're doing for novel approaches to patients with higher risk MDS is getting better at classifying their prognosis and distinguishing who's truly higher risk from who's lower risk in MDS categories. We're using combinations of therapies, and we're targeting the molecular profile better and better. Thanks so much for listening today.